Welcome to Heroic Herstories, Women in Medicine with the Katies. This podcast is to document the stories of women trailblazers in medicine in the state of Iowa. We will highlight seasoned women in medicine to create a brief oral history of their works and lives. We want to learn from their experiences, share their vast knowledge, and gain insight into the challenges they have faced. Our goal is to lift up those who have gone ahead of us and thank them for their incredible service and dedication to our wonderful field. Hi, Katie.
Hey, Katie. I must say before we start, this has been a tech challenge today for us.
And we overcame it, though.
We did, and our guest has been so kind to us while we've been going through all these problems. So
very patient, as patient as I would expect from a pediatrician.
Honestly. That's true. That's true. I think our audience is going to be shocked when we talk about this. But I get to introduce the wonderful Dr. Mary Beth Fasano. Yay! Welcome. Thank you so much for joining us. Dr. Fasano, how would you like me to refer to you today?
Mary Beth would be perfect. Thank you, Katie.
Okay. Well, I get to give some of your background here. So Mary Beth attended Johns Hopkins University for her undergraduate studies and graduated in 1978. She then went to the University of North Carolina and completed her Master's of Science in Public Health in 1981. She went south to Lubbock, Texas, where she attended Texas Tech University School of Medicine and graduated in 1985. She returned to Johns Hopkins for her residency in pediatrics. Woo! We're so excited. Who knew? And then was inducted into AOA during her residency, which is a medical honor society for anybody who doesn't know. She then completed a one-year research fellowship in infectious disease at Wake Forest University Medical School and was once again drawn back to the Johns Hopkins for her fellowship in allergy and immunology. She was on faculty at Wake Forest for 11 years prior to coming to the University of Iowa. She was a fellowship director for the for the allergy immunology program here for 18 years. She has won many awards, especially in her medical specialty societies, and recently, in 2023, was awarded the American Academy of Allergy, Asthma, and Immunology President's Award. And of note, when we were digging into this, because we're practicing our journalistic, processes, we found that she was, I believe, the fifth woman president. Only the fifth woman president. And this organization has been around since 1944, and they assign presidents every single year. So pretty notable. She's also been active in research throughout her career, studying food allergies and primary immunodeficiencies. And we are just so happy to have you with us today. So thank you again, Dr. Fasano. I'm giving you a round of applause for you and for all of your patience with us today. So thank you.
You are welcome. Boy, you made me sound like really good. Almost too good to be true.
No, the fact is, Katie and I talk about this. We always feel like we sell you guys short because your CVs are so amazing. And we try to summarize it in this little capsule when there's so much more to you and to your career. So hopefully we'll get to talk about some of those things today. Yeah.
A big reason why we have to cut it, summarize it so much is that there are a lot of words that we don't know. So we really have to stick with the words we know, and that's pretty limited. So that's why we end up summarizing it so tightly.
Yes, we've gotten good at that.
Mary Beth, we noticed that you've been all over the country, really, in a lot of different regions, Texas, North Carolina, and you settled in Iowa, which, we have probably the worst weather in the country, especially compared to other places you've lived. So we always start with just to get your feet wet with the hard-hitting journalism here at Heroic Herstories. If your personality could be described in weather terms, what's the forecast?
82 degrees, sunny, low humidity, and no chance of tornadoes, hurricanes, derechos, or dust storms.
Impressive.
Perfect
weather. But by the way, I should mention this. I'm a native Baltimorean, or Baltimorean, as they
they don't say that.
Do people say that?
That's not what they say.
Well, back in the day, we were the Baltimoreans. it's a great city, a great place to grow up. But I'm trying to think, when I was in Baltimore, we had snow, hailstorms, and hurricanes. In North Carolina, we had hurricanes. When I was in Texas and Oklahoma, we had tornadoes. Iowa's the only place for the derecho. Let's
Yeah.
hope that doesn't happen again.
So strange.
That was
I
a wild
know.
day.
I
Yeah.
know. Yeah.
And
Yeah.
had any of us heard of a derecho before that happened? Yeah. Me
No.
neither. Okay.
I hadn't.
That is for sure. Okay, well, so now we know that we have like a perfect day forecasted for our
Beautiful.
interview.
Yeah.
We're feeling good about that. Okay. Well, we like to start from the beginning with all of these amazing women we get to talk with. We just wanted to hear, why did you choose medicine in general? And then, because you're a pediatrician, we have to ask, why pediatrics?
Well, at first I wanted to join the FBI.
Hmm.
Yeah. And then, because I was very interested in investigating things. And then I was a nerd, one of these, I was a nerd. So I had read Microbe Hunters and Snow on Cholera, John Snow's description of the Broad Street, London cholera outbreak. And so I was all excited with this. So then I was going to be the president of the World Health Organization, or I was going to join the CDC in their epidemiology intelligence service. I was going to be an EIS officer. But then as time went on, and I did end up going into public health, but I just found that more and more I was drawn to a service-oriented field with direct patient care. And I had some wonderful mentors. And, I don't know. It really, really resonated with me. So there you, yeah. And thus the journey began. And I did not join the FBI. Probably, thank goodness. But
No, they're lost. They're
Was
lost.
that cholera book the one where he figures out like that it all comes from the same well or whatever?
Yep.
Is that story?
Wow.
Yeah.
Nice.
Yeah, that is some good detective work
Yeah.
done by that guy. We don't usually highlight the work of men on this podcast, but
It's already well highlighted.
yeah, we didn't do it, but
Yes. Wow. Okay.
That's
So
all right.
that's your medicine choice. Then what drew you to taking care of the children? The children.
So, Katie, I have to tell you, I always thought I was going to be an internist. I didn't want to be one of these like baby doctor kind of things. But there were probably 2 or 3 big reasons. One of them is, so I'm doing my medicine rotation as a medical student, and I'm seeing, stroke, MI, coronary artery disease, obesity, osteoarthritis, type 2 diabetes, and, okay, all right already. And then I rotated through pediatrics, and I'm not seeing stroke, I'm seeing neurodevelopmental disorders. I'm not seeing myocardial infarction. I'm seeing complex congenital heart disease. I'm not seeing type 2 diabetes. I'm seeing more type 1 or autoimmune based disorders. And the other thing that absolutely fascinated me is I started seeing syndromes. And so it wasn't just complex congenital heart disease, coarctation, it was in a baby with DeGeorge syndrome. I saw Wiskott-Aldrich syndrome, and well, that I may be getting into the immunology piece, but I found that I was drawn more to conditions and disorders that perhaps people were born with, as opposed to, and I'm sorry, I don't mean to offend any of the internists on the podcast, but some of those disorders I saw as, it was the environment and you didn't take good care of yourself. I was more fascinated in what happened way at the beginning. So part of it, again, was the types of disorders and conditions that a pediatrician would see. And then the other piece was just mentors and people that I worked with. And I just found that the personality of the pediatrician a little bit more, I don't know, low key. We see this from time to time. Um, just more warmth. Again, no offense to any of the internists. I'm married to one, as you know. But I guess that was, and I tried to convince myself that I did not want to go into internal medicine. That I really wanted to go into internal medicine. I didn't want to do pediatrics, but it didn't work. I couldn't play those mind games for too long. And so finally it was just, all right, already, suck it up. You want to do peds. And yeah. So
But I mean, that fits with your like investigating into the root cause of things, right? Like your FBI type of stuff. Because like a lot of our stuff, not all of it, but a lot of times in internal medicine, we're like, yes, we know why you have type 2 diabetes.
It's more consequences than it is root causes.
Yeah, that's fascinating. And it's kind of funny because Mary Beth, I really wanted to do peds because I felt the people. I felt like I fit in better with the people. And so I kept having to convince myself, like, actually, that's not the kind of medicine that's interesting to me, So I was the complete reversal of you. So, but that brings up, so I admittedly, we've worked together for a long time and I never realized you were trained in pediatrics. So can you tell us a little bit about that pathway for, allergy, immunology? Can you do internal medicine? Can you do peds? And tell us about that.
Oh, wow. So for allergy immunology, which is a fellowship program, you can come into that pathway either through internal medicine residency, a pediatric residency, or a med peds residency. So I entered that fellowship through the pediatric pathway, but actually, and then during my fellowship, I had a lot of adult patients.
Okay. That's what I was wondering.
And I really enjoyed that. And then I think it went back to, I always thought I wanted to be an internist until I went into pediatrics. So for me, I think it was not only investigative, not only immunology, because by the way, Katie's immunology is everything. Everything is immune system. But it was a way then for me to work with adult patients as well as pediatric patients. Something I call womb to tomb or cradle to grave.
Were you as scared to take care of adult patients as we are as internists to take care of pediatric patients?
No.
Okay.
I swear, I think it's easier for the pediatrician to see adult patients than it is the reverse. And let me tell you why. You spend time on adolescent medicine as a resident, and you are working with those adolescents. Working with adult patients is a walk in the park.
Mm-hmm.
Yeah. The other thing, actually, a little bit of a tangent, because or maybe I don't know if you noticed this or not, but I used to staff the VA allergy immunology clinic here in Iowa City. I swear, I think I was probably the only pediatrician who ever worked at the VA. But you guys know, you go over to the VA and it's the older vets, and oftentimes who's bringing them in? Their son, their daughter, the family. And so I found that some of the communication skills that I had developed as a pediatrician fit in perfectly with meeting with that 86-year-old vet whose daughter was bringing him in for an appointment. Anyway, I went off on my tangent there, but anyway.
We love tangents.
And pediatricians are, they are the sort of the experts in communicating with family in the room, right? So, communicating with your patient and also their family members and making sure you're talking to your patient and incorporating because they're, pediatricians, patients definitely need the caregiver engagement. And so I can definitely see what you're saying there. That's a good point. Do you have a sense for why it is that allergy, sort of uniquely among the specialties that internists go into, why it takes people from peds and adult medicine?
So actually, there's a little bit of Iowa history here. Way back, probably in the 40s and early 50s, the American Board of Internal Medicine had a allergy immunology subboard, and the American Board of Pediatrics had a separate subboard. But it's a very, very small subspecialty. And also, it's all the immune system. We're not an organ-based subspecialty. We are a mechanistic-based subspecialty. And the immune system, that's the big umbrella term, develops in utero, in childhood, into adulthood. So a lot of what you do as an allergist immunologist is not necessarily age-based. So way back in the day, Dr. Paul Seabaum, who was here at the University of, if you've ever been to the Seabaum conference room, that's named after Paul. He was the division director of allergy immunology here at the University of Iowa. Paul was instrumental in forming a new board called the ABAI, the American Board of Allergy Immunology, which is a conjoint board of the American Board of Pediatrics and the American Board of Internal Medicine. And thus, the two sort of merged. So the entry path into that fellowship is medicine peds or med peds. And then we have a separate ACGME review committee and a separate certifying board. So it's not a subboard of ABIM or ABP. We are our own unique entity, the ABAI. So I guess we have Paul to thank for that. Yeah.
That's so cool. I love
a
that
real
you
pioneer.
explained that. Yeah. And I also, just looking, you also did research in infectious disease, which
I
is
did.
also kind of one of those like umbrella type of things. So you were really going after like the mechanistic type of studies, it looks like.
Another thing that, go ahead.
I was just going to say, you heard my little torn between should I go into medicine or should I go into peds. I was also very torn between going into infectious diseases versus allergy immunology. I really loved the ID folks that I worked with. It was that investigative piece. But as time went on, what I realized is that I wasn't a drug and bug kind of gal. No offense again to the ID people, but it just seemed as though some of my experiences as a medical student or a resident, it was you identify the bug and then what's the antimicrobial that you would give to clear it. What I was how the host got rid of, not how the drug got rid of the bug, but how the immune system or the host's response to that bug aided in clearance or inability to clear that particular pathogen. So I then ended up like I said, gone into allergy immunology because it was the immune system that absolutely fascinated me. Yeah.
I'm just so happy that you're so excited about the immune system. Some of us are a little more intimidated by it.
The two of you, you're budding immunologists anyway. Maybe you just didn't know it, because I guarantee you, every single patient that you see, whether it's outpatient medicine or inpatient medicine, you're dealing with the immune system every day. Because even in the simplest form, what are you doing? You're recommending the flu vaccine to your patients.
That's
And
true.
what does that do? It boosts the immune system. So you get your protective antibody and you get your memory T cells to fight that off. So there you go. We're all immunologists. We can be proud.
Nobody who has seen my medical school transcript would say that I'm anything resembling an immunologist. That was a dark block of medical school for sure.
But I'm sorry, then we'll get back on track. But I also felt like my immunology book was like this big, and like like how
You're old.
I know. I'm happy about that because, like, look how much the students know now about immunology that we didn't. Like, it's amazing. Yeah.
So another thing besides, bringing in this era of dual pathways to allergy and immunology in the state of Iowa, the University of Iowa was also, the first medical school west of the Mississippi to admit men and women on an equal basis. I don't know if we've talked about that, I think, here, Katie. But that's a fun factoid about the University of Iowa. And you told us at a social gathering about your medical school experience a little bit. And I was wondering if you could tell our listeners about your experience in medical school.
It was a great experience, but it was very different from the environment that we have now. I was one of 9 women that graduated. We actually started out we had 10 women in our class of 100. And then we did have one that ended up dropping out. So it was very much a male dominant field, not only, back in the day, but also where I happened to go. But, even going back a little bit further, I was rogue when I was younger. When I was in high school and applying to some colleges, I got a couple of these Dear Ms. Fasano letters back. We don't accept women. They were all male universities. And in fact, my freshman year at Hopkins was also the very first year that they graduated women from their undergraduate campus. Now, that was different. Hopkins Medical School, founded back in the 1800s, accepted women from the get-go. But my college experience was also a male dominated experience. And actually, maybe that's okay, because at the time that I entered into medicine, it was so male predominant. Over time, you kind of you toughened your skin a little bit and learned how to have conversations with men and women. We communicate differently. And learn how to sometimes let things roll off your shoulders versus, nope, you gotta feel comfortable stepping up and saying something. I also, and maybe this isn't fair to say, I don't know if we really worked any harder than our male colleagues. And here I am in medical school, but I think we actually really did, because we felt that we needed to work harder to excel, to be accepted in what was a male dominant field at that time.
Sure. before you had gone to med school, you did your master's in public health.
Mm-hmm,
Is that right? And was
I
that
did.
part of that career exploration? Like, do I, how do I want to use my investigative skills? Or was there anything that, did that push you towards medical school?
Um, Actually, I hadn't mentioned this earlier. There was a not so good experience that I had in college because I was leaning towards medicine, but then ended up pursuing the public health. And that was actually for two reasons. The most impactful reason was I think I was a sophomore in college. And I was taking a course called Issues in Healthcare Delivery. It was through the chaplain's office at Hopkins. And we were all assigned to do like a hands-on clerkship in a healthcare system for 3 months. And I ended up being assigned to the Johns Hopkins Hospital Emergency Department. And so we're talking about a hospital that is in inner city Baltimore, not necessarily the coziest place to be. Lots of gunshot wounds, stabbings, things like that. So I loved that experience. But one night I'm working over there in this role as quote unquote a patient advocate. And in comes a young man with sickle cell disease having a pain crisis. Baltimore, by the way, actually has a huge Black population and a lot of patients with sickle cell disease. And I can remember we were chatting and he was in so much pain, and the emergency department resident came by and just started laughing at him and saying, "You are making this pain up. You are just a drug seeking, blah, 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 blah." Delete, delete. I'm not going to say the rest of the conversation. And this young man was on a gurney in the hallway. And during part of this confrontational dialogue, sort of reached over, fell off of the gurney, and the resident just laughed and walked away. I was devastated. I can remember going to my little mentor after that. I was devastated and emotionally quite upset, and had to do a debriefing. And it was like, there's no way I'm going into medicine if these are the type of people that I'm going to be working with my colleagues. That was, and it really took me a long time to come back around. And so I ended up, because there were investigative things, things about, remember, I wanted to be an EIS officer.
Mhm.
I wanted to be president of the World Health Organization. So I thought public health was my path, which I really enjoyed that. But during that master's degree program, I actually ended up doing some research at the NIH with individuals who were all physicians, and by the way, also all pediatricians, who were great people, great mentors, great coaches. And they helped me to reflect on that one isolated experience. And that really wasn't what medicine was all about. But isn't that something, how sometimes just one chance encounter or experience can shift what we do and why? Yeah.
It always makes me think, I mean, and you were, a patient advocate, or, you weren't the patient, and this still impacted, I mean, obviously it was an incredibly awful situation, but it is something to remember that like everybody in that room, like has a point of view and a perspective, and
Mhm.
how your entire life kind of curved around that moment. It's quite amazing. Yeah.
Yeah.
Oh, I'm glad you found your way back to medicine.
Well, I did. And actually, I had so many other wonderful experiences with physicians. And both before that episode and then certainly following that, and that that grounded me and helped me to get back on track. Yeah.
I was
Yeah.
curious with all of your work at the NIH and seeing these amazing physician leaders. I mean, you took a lot of leadership roles in professional societies, and I'm just curious. Was that part of the? I guess was that influencing for you? That earlier stage in your career. Did that make you want to be more active on a national level, or what prompted you to be so active in the national societies?
Um, You know, actually, Katie, I think it was just kind of much simpler than that. It wasn't that I was aspiring to be a leader, is that, if I can use this term, volunteerism. I love the spirit of volunteerism as a way to contribute to medicine, as a way to contribute to allergy immunology, and also is a really cool way to like connect with people, get to meet people and work with people that I otherwise wouldn't have met. And it was very, very rewarding. Um, and I found that really kind of starting out, what I liked was I wasn't the leader. I was the boots on the ground kind of volunteer person working, saying, oh, yeah, I'd love to work on that project, or here's a cool idea. And I just got to meet a lot of people, have fun. I liked the diversified portfolio. I don't know if you know,
Hmm.
what do I mean by the diversified portfolio? I mean, we're all very busy, but sometimes, oh man, life at the academic medical center can kind of get you down.
What?
Really?
Yeah,
That
yeah.
doesn't sound right.
Um, this or that. And so having the opportunity to do something outside of my day job um, actually was a way that it invigorated me. It helped me to be able to sort of put some of the it was kind of a bad day at the U thing aside, and then have fun with some of the volunteer work, and then built up into leadership roles that I had.
I love
So
that you use that word volunteerism, volunteer work, because I think a lot of
yeah,
people, think that they don't think of these like medical societies as being volunteer work. And I'm like, that's a lot of time and you're not getting paid for it. That is the essence of volunteer work. And you're really like, you're putting forth so many, great ideas and ways to elevate your, medical specialty. That's really amazing work. So thanks for that. Yeah.
you are welcome. But and Katie, one other piece, getting paid for it, it depends upon how you
Good point.
define payment. And
Good
it
point.
doesn't always have that payment doesn't have to be financial.
Yeah.
Or that payment doesn't have to be, oh, I get to put something on my CV.
Yeah.
That payment can actually be, I got to participate in a group that created a workshop, or that wrote a paper, or I got to like meet and work with really cool people throughout the country. That type of payment, that enjoyment, that connectivity, that contribution, um, better than money.
So much better.
Yeah.
Yeah.
Well,
Yeah.
and we've had conversations in this space with women who've said that those sorts of relationships were what allowed them to then take next steps in their career too.
Yeah.
You know, it's an investment of time and energy in networking and getting to know people who then recommended them for another position or mentored them when they were trying to figure out what their next step was. Like making those connections is how you, you know, mentorship is better if it's sort of natural and rather than assigned, I guess, like by your
I think
department.
that's true. Yeah. Yeah.
And so then you were the fellowship director here at the University of Iowa for 18 years. That's a long time to do any job. Tell us about your experience as a fellowship program director. What made you choose to do that?
You know, I actually started in that role when I was at Wake Forest. Before then, leaving to head to Iowa. My journey into graduate medical education and into as a program director was probably several fold. One is I love to teach. I love being involved with physician learners. I had started out my academic career with some NIH funding and a research lab, but that I wasn't getting the publications or the follow-up research grants to sustain that and to keep a lab and keep a lab technician and so forth. And so in talking with some of my early mentors, as I was thinking about ways to sort of reshift my career path because of my interest in teaching and working with residents and fellows, I guess maybe they recognized that might be something that I would enjoy and something that I might be good at. And so they gave me the opportunity, and I ran with it. I don't think I knew that then once I came to Iowa, I was going to be in that role for 18 years. It's just the way that it panned out. But I've seen lots of fellows come and go, and they're all amazing people. So bright. I think, oh my God, I would never have been able to get into an allergy immunology fellowship in these days. I am like so dumb. You know, they are just such bright, energetic individuals. So it was a pleasure to be able to serve as their program director. They may not have thought it was a real pleasure to have me as their PD, because I could be pretty harsh. Because my goal sometimes I'd push them maybe too much because I wanted them to be the best trained allergist, immunologist that they could be. And sometimes that meant, yeah, you're doing a great job, but pushing them a little bit further. So I didn't hesitate to give feedback, and maybe that feedback wasn't exactly what they wanted to hear all the time. Yeah, you're doing a great job, but you know what? Wouldn't we get stagnant if we didn't have something that we needed to like work on or try something different? So
well, and they were expecting hugs from a pediatrician, and it sounds like you were giving them internist.
I was giving them that.
You were giving them internist, try a low carb diet. You were giving them internist, you need to exercise. Right?
You internist. I knew you were harsh. There you go.
That's where it is.
Yeah.
The closet internist.
Yeah,
that's what happened.
That's your fellowship director side.
Shoot.
Yeah.
Now I know.
So happy we helped you figure that out
That's right.
today.
Thank you. I feel like
I
we've
do
made a lot
too.
of strides today.
Yes. Now, Mary Beth, we had to ask, and I'm sure so many of our many, many listeners are also curious. We wanted your professional opinion on this. So, why are there so many kids with food allergies now? I mean, I have to give the example. I have 3 children. 2 out of my 3 have peanut and nut allergies, and I was really struggling to think of a single person in, my grade school or high school with a nut allergy. And I don't know that I could think of anybody.
And Mary Beth, I just want to, as a mandatory reporter, I want to let you know that Katie has peanut butter hidden throughout her house, not locked up. It's just
I eat it every day.
It's just around. She eats it all the time. It's all over her fingers.
I wash my hands. Let it
seen
be known and brush my teeth.
I'm shocked. I'm shocked.
Yeah.
But you know what,
Yeah.
Katie? That goes back to our little saying in food allergy: eat early, eat often. And I'll go back to that in just a minute, because you're asking why. And it's not just food allergy. If I can use the term, atopic conditions in general are increasing. So that's asthma, allergic rhinitis, allergic conjunctivitis, food allergy, atopic dermatitis, and even eosinophilic eosinophilic esophagitis are all increasing. Now, part of it is probably, we know more, so increased recognition. Some of it is obviously genetic predisposition, but a lot of it is the environment and how the environment has impacted on that genetic predisposition. So a lot of the exposure that we have in our environment with pollution and climate change and global warming have impacted on the prevalence of environmental allergens, pollens, things of that nature. And then going specifically to the food allergy piece, and I've got the gray hair, so I'm allowed to say this. Back in the day, in the dark ages, when I was a pediatrician and a budding fellow in allergy immunology, what we were taught to do is you don't introduce highly allergenic foods to kids until they are even up to 4, 5 years of age. And so that was the strategy, particularly in kids who were born into an atopic family, to be able to stay or stop or prevent food allergy. And in fact, the American Academy of Pediatrics Allergy Immunology and Nutrition group had guidelines that you don't introduce egg, peanut, tree nuts until the choking hazard piece aside, until you're older. Well, wrong, wrong, wrong. And why it all goes back to immunology is that the best time to train the immune system to recognize a food as, hey, this is okay, I'm going to tolerize to it, my body's going to be fine with it, is to do it with the immature immune system when that infant is young, as opposed to delaying the infant or child's exposure to that food allergen or antigen until they're older, where the immune system has already started to shift, and then you're exposed to it and you don't tolerize, you sensitize to it, and then you develop the food allergy. So now, this has been a huge paradigm shift where now allergist immunologists, pediatricians, the American Academy of Pediatrics are eat early, eat often. Start giving that baby thinned peanut butter when they're 4 to 6 months of age, not wait until they're 4 to 5 years of age. And yeah, by the way, I had to do my little immunology. Did you notice that?
I
I had to
love that
get
you
that
got
little
it in there.
immunology
Love it.
lesson right in there. But
Well, so does what's in the
anyway,
breast milk matter? Like if it doesn't, do they get anything from what the mother is eating?
yeah, some, although the exact amount, and if it's a consistent pattern is unclear, but yes, some trace amounts of those food proteins can cross through the breast milk. But now we've also changed recommendations where back in the day is if you had a food allergic kiddo or whatever, the mother, if she was nursing, had to avoid
Right.
all of their foods. And do you know how hard that is to do? And if someone's trying to do that, you know what, am I gonna like starve myself and continue to nurse my baby, or let me just buy that infant formula, whatever? Yeah, that was really, really hard. And now also there's been a paradigm shift and a change in that, where early exposure of the infant to those food allergens is like really good. And we don't have to terrorize moms who have young infants and they're not getting sleep at night. And then you're
I mean,
trying to tell them what they can and can't eat.
I
Yeah.
think my takeaway from this is the fact that I was shoveling peanut butter in my mouth while nursing all of my babies. I'm just going to say it's genetic and from my husband. I'm just going with it. I'm just going with it because they'll always blame the mom. I'm just going to say this case,
Yeah, they
dad.
do. They always bring them up.
Your little controlled experiment in your own house.
That's exactly right. Direct inoculation into mouth, into breast milk. So, okay. Moving on.
Fantastic.
Thank you for that immunology lesson.
Yes, you're welcome. You're welcome. Oh, man.
So Katie and I are frequently having conversations where we find out that two people in the department are married to each other. And, fortunately, I don't think either of us have put our foot in our mouth yet with regards to,
Speak for
dragging one
yourself.
spouse to another. Yeah, you probably have. That's true. Katie probably has. So, and I know that your husband works here at the university and you have different last names.
Mhm.
And we were talking about whether it was an intentional choice to not change your name for professional reasons or what kind of led to that.
Actually, it was a selfish personal choice because by the time I'd gotten married, I'd already graduated from medical school. I had already completed my residency. So my medical diploma and my medical license and my board certification all had Fasano. And
Mhm.
frankly, when I went to my husband, I said, to like change all of that, I'm too lazy. I don't want to do
Yeah.
all that. And he goes, well, don't. And
Yeah.
he was 100% fine with that. And he also said, by the way, I have a very boring last name. Fasano, yeah, let's keep a little Italian flair. So it really was that selfish reason. I was too lazy to have to go through all the paperwork to change my licensure and certification and diploma. And my husband was 100% fine with that.
Yeah.
So there you go.
Have there been any circumstances where somebody will be talking about your husband and you're like, it's my husband, or no, where they didn't know?
Actually, not that often. It's been more the reverse, where actually, sometimes we would have some shared patients, and I might be doing an allergy immunology consult on a patient that was on the Gen Med inpatient service, and my husband was the attending at that time. So I'd be up seeing the patient, and then we might be talking at the bedside, and my husband was known to be saying, "Okay, love you, see you tonight." And then like you'd see this like look come over the patient's face, like what? Because we hadn't identified ourselves as being, and then he'd go, "Oh, that's okay." That's my wife. So it was actually
sweet.
more, and he loved, kind of pulling that little trick on patients sometimes. So yeah.
Knowing your husband, that doesn't surprise me, and I love them.
Yeah, yeah.
All right. Is it time for rapid fire questions, Katie? Are we there?
I think we're ready.
It's gone so fast. Okay, we're gonna go. We're gonna go to our rapid fire questions, Mary Beth. So get ready.
I have like how many I can answer in 30 seconds, or
Okay, we will cut you off.
Yeah, we're gonna be like, stop. No. Don't worry. We still
Okay,
let you chat as much as you want.
Katie has a buzzer.
Yeah. I should bring in my little taboo buzzer. Yeah. All right. First one. If you could go back and meet yourself on your first day of internship, what would you tell yourself?
What did I just breathe?
That's a very good tip. Okay.
Take a deep breath. Yeah, that's a good one.
Just take a deep breath. And I guess the other thing was embrace the opportunity to learn from your mistakes. Because doggone it, everybody makes mistakes. It's okay to do that. And as I think back to the mistakes that I made, that's where I really learned the most. And fortunately, I was in an environment where I didn't do anything that was really, really horrible, dangerous. And that I also had coaches and mentors and colleagues who had done those same things themselves early on in their careers, and were that helped me to learn from that.
Great.
I think it is because that's a very common answer is oh, take a deep breath. It's going to be okay. Everything's going to be fine. And I think it's really interesting that you follow up with that about taking advantage of the opportunity to learn, because I think we frequently feel the weight of the responsibility a lot as a resident, as a house staff, and there is so much backup. And I think you don't realize how much backup there is for you when you're in the house staff, at the house staff level. There are people watching, there's people who can fix basically anything you do. And so I think I definitely didn't appreciate that until I became an attending, where I was no, I can kind of fix whatever the resident, I can handle whatever the residents come up with. And I just felt I was everything I did was life or death when I was a resident, which is a lot of responsibility. So, but I think I would have relaxed more and maybe felt a little bit more open to learning if I wasn't so worried.
Yeah. Sometimes it's harder to recognize what you don't know than it is to recognize what you do know. And in fact, if it's hard for you to recognize what you don't know, then it's hard to actually ask for help.
Yeah.
It can be harder to ask for help, and you just don't learn as much. You really have to sometimes put your ego aside, if whatever, and say, I don't know. I need to ask for help.
Love it.
Yep. What is one thing in medicine, peds or adult medicine, that grosses you out?
I don't know if I'm not sure anything really grossed me out, but the one thing that internal medicine didn't have that peds had, when you were on the general peds service, they had the little snack room. And they had all the saltines and the graham crackers. And Katie, they had the little peanut butter.
I love those cups.
And so I guess maybe it grossed me out that when I was doing my internal medicine rotations, they didn't have the snack room where I could get my little snacks. Yeah.
That's disgusting. I could tell you where every snack is. Yes, like the sugar-free Jolly Ranchers, the salt packets, the graham crackers. In residency, we had an oatmeal little packs. I loved those.
Oh, did you? Yeah.
Wow. Okay, so you don't get grossed out. That's impressive.
Maybe that. I love germs.
Yeah,
I don't mind. I don't mind getting
That's a good point.
dirty.
Good point. How about the
So, yeah.
placenta? I just want to ask about that. Placenta, does that gross you out?
No, not
Ah,
at all. Not
hmm.
at all. I mean, I delivered 21 babies as a medical student.
Wow.
OBGYN was my very first clerkship. Again, remember, I grew up back in the day, like where there were no duty hours. People were
Yeah.
still on call every second or third night. As medical students, we took overnight call. And literally, I mean, there would still be the resident in the background, but I caught lots of babies.
And those
And
terrible placentas too.
yeah, but no, I didn't mind that. It was attached to the baby. It came out
I
afterwards.
know. I
Katie, think
know.
of like how
Oh,
immunologically special that placenta is, though.
don't
Think of
lecture
the
me on it.
immunology.
I know. You can logically know something and still be grossed out by it. Okay. All right. I'm going to
Okay.
move on. I'm moving on. To something really cool. We love to ask women physicians about menopause. Any thoughts you'd like to share with our vast audience about menopause?
One word, ice packs.
Ice packs. Okay. To the armpits? To where? Where do we put these
Oh,
armpits?
yeah, I'd have
Everywhere.
several. I mean,
Neck?
they'd be everywhere. I put them on my back, up here. Yeah. It's amazing what
Ice
ice
packs.
can do. Let
Okay.
me just say.
Love it. That's wonderful.
Yeah.
Good. Good tip.
Yeah. Any embarrassing situations you could share that you could laugh about now? Like passing out in the operating room, maybe?
Oh,
Did you drop any of those babies?
oh, now come on.
That would have been embarrassing.
No. I never dropped a baby, even the slippery ones
They're slippery.
coming
Yeah.
out. I never passed out in the operating room, nor did I fall asleep holding the retractor as a medical student, which sometimes, we had to do. But I guess the other end, my pager into the toilet
Yes.
twice.
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 Yeah. But once was like as a resident, the other was actually not that many years ago.
Last week.
But part of it is, back in the day, I mean, I although I might wear scrubs, I also liked to wear clothes that I enjoyed and tried to look professional in, and so on and so forth. And so, where the heck are you gonna, if you happen to have a dress on,
Oh,
you
yep.
have to, you're
Up here.
clipping it, up here or something
Mhm.
like that, or you put it into a pocket, or it loosely fits on. Actually, back in the day with scrubs, I mean, it was a one size, even the small sized scrubs did not fit me. Let me
Yeah.
tell you, I had to wear like a shirt underneath. Otherwise, the cut
Oh, yeah.
line was so low. And then trying not to trip on the pant legs because they were so long, and really tying it around or whatever. So, anyway, it was just really hard sometimes to figure out where to put your pager. So, yeah,
We
the
feel
toilet
ya.
once or twice. And the best part is like, so I went to like the little IT booth
Mhm.
or whatever and I had the pager in my hand. No, but I'd wiped it off or whatever. And I go and I'm saying, oh, I wanted to turn this in because they dropped it in the toilet. You should have seen the expression on this woman's face when I said it dropped in the toilet. So she quickly went, put on some gloves, and it was like this,
They have to be
radioactive.
used to this by this point.
Yeah.
I mean, come on.
And
Pagers fall
in
in
a
the
hospital,
toilet.
like pagers in a hospital, there has to be worse stuff.
Right.
Yes.
Yeah.
Oh,
Like my pager fell into someone's body cavity, for example,
Or even just
you know
anywhere in this
what?
place.
I just thought of something. I don't know if any of you had this experience, but I lost an earring in an infant diaper.
We don't do babies, Mary
Yeah.
Beth.
I know.
Mm-mm.
And I swear it was hysterical. It was in like the step down ICU unit. And I'd been over examining this infant, and I don't know. And, you zip off the diaper, whatever. I'm checking things. And I don't know, my earring just kind of fell off. And then I'm over in the unit at this little desk area, completing my notes, not too far from this infant's bed. And all of a sudden, I hear this nurse just laughing like all get out because she's changing the infant's dirty diaper. And what did she find in it? She goes, "Oh, Dr. Fasano, look
That's
what I found."
That's awesome.
So you just rinsed it
But-
off and put it right back in then, I assume.
Yeah, that's right.
Actually, that was like a really dirty diaper on a sick kid. So, and they
So no.
were not like a special earrings. So it did go into the trash can.
Moved
Yeah,
on.
yeah.
Yeah.
Yeah, I
That makes
moved on.
sense.
Good
Yeah.
job. It's a good
Mhm.
choice.
Yep.
Moving from dirty diaper to what's your favorite candy? I feel like that's okay for us to make that quick transition.
No, peanut M&Ms.
Oh, Lois Geist's favorite. How about,
Yeah.
do you put them in the freezer?
No,
puts them
I
in the
don't.
freezer.
But Katie, I don't know. Maybe you were never in my office, but I had a peanut M&M dispenser
Oh,
in my office.
was it an M&M shaped guy who went like this?
It didn't have the hand that went down, but it was the little like M&M dude. And yeah, and it would accept both peanut as well as plain M&Ms.
Impressive.
And I would go to Costco and buy those really big bag, how many, like 5 pounds, I don't know how many pounds, and bring those in. The downside is that although I would share the M&Ms with whoever wanted to come in to the office area and this or that, I probably consumed 90%.
Oh, yeah.
of it. Yeah.
There's no downside to that. It's
Yeah,
delicious.
well, yeah.
Great protein too. Mhm.
Exactly. Peanut, great source of protein.
Love it.
I'm with you.
Well, we're so thankful for you spending time with us today, Mary Beth. I hope you enjoyed the experience as much as we did.
Well, you guys are welcome. I had fun. I hope you two had fun as well. And thanks for hosting this podcast. Stories can be so powerful. They really can be. And everybody has a different journey. And I just love hearing them. So thank you for letting me share some of my stories and my journey with the two of you.
Thank
We
you.
appreciate it.
We had one story, a historical woman
Mhm.
who Katie was going to share about. If you had just a couple minutes, you're welcome to stay on. If not,
I'd love to hear the story so I can.
Yeah, it won't take too much of your time, but
Okay.
she was chosen just for you.
yeah.
No pressure.
Okay.
So our historical woman, this episode is a Dr. Martha Wolstein. She was an accomplished physician, researcher, and the first North American pediatric pathologist. Do you know about this doctor, Mary Beth?
I don't.
She's always pimping people.
Now.
I just don't want to try to act like an expert when I've got an expert here.
Mhm,
I do that all the time. It's terrible. All right. So she was born in New York City in 1868. To one of the few families that we've reviewed in the Historical Woman series that actually supported her education. They were very excited about her going to medical school. So she got her MD in 1889 from the Women's Medical College of the New York Infirmary. And then she interned at a hospital called Babies Hospital.
I love it.
Which is maybe the best
Babies.
name. It's like, what's this hospital for? Babies. Okay, we'll call it Babies Hospital.
I love that.
Yep.
Yeah,
In
yeah.
1891, she was appointed its pathologist, which was a really big deal at the time because she, did patient care, she did bench research, she did autopsies. And so she was really kind of in the middle of everything at this hospital, at Babies Hospital. And that allowed her to get started on a career that was really very research heavy. She was able to do a lot of really interesting research. So she kind of ended up being mentored by Simon Flexner, the brother of Abraham Flexner of the Flexner
Wow.
Report.
Yeah. Yeah.
And so she was working with Simon Flexner on bacterial causes of infant diarrhea. And she ended up isolating Shiga bacillus that was causing dysentery in these
Yeah.
babies, which
Yeah.
relates to your baby earring story.
Oh,
That's a reason not to put that earring back in your ear.
Right. Nobody wants Shiga.
No. But so she ended up being sort of promoted to a research position where she was funded by the Rockefeller Trust, like the Rockefeller Philanthropy, which was the same thing that supported Norman Borlaug in his wheat research. Katie, your kids would have worked with that. So in that position, she did a lot of research that was pediatric, not pediatric. She did she continued at the baby's hospital. She worked on TB in babies, did the first study to provide data specific to childhood TB. She did anti-meningitis serum. So she worked on vaccination for a big part of her career as well, which is a very nice pediatric topic. She was doing research on, because apparently, so she kind of came of age right around the time, and that's when she really got involved in the immunology community, right around the time of the influenza pandemic. And at that time, one of the concerns was that Haemophilus influenza, the bacteria, was one of the causes of influenza, and they kind of were working through that question. And she did a bunch of research that provided evidence that no, the bacillus was a secondary infection when people would get on top of influenza, but it was actually a viral illness. She did a lot of research on childhood diseases, especially mumps. She figured out that mumps was a viral illness as well. She published more than 60 scientific papers, did numerous honors, and she was appointed the head of the pediatric section of the New York Academy of Science in 1928, and she was elected to the American Pediatric Society as its first female member in 1930. So she was sort of on the forefront of a lot of research that's very relevant to us now when we're talking about vaccines, vaccine safety, the importance of childhood, of prevention of these illnesses in childhood and then into adulthood. And she was doing that, 100 years ago, which is pretty fascinating. And now we're having to revisit all that and reprove all of the things that she already told us. Just sort of dark, but I thought she was a really interesting example of a woman pioneer in immunology. And I wanted to talk about the baby's hospital because I wanted to say baby's hospital. And yeah, that's it.
Love it.
That's
What a great one.
Mm-hmm. Yeah.
Wow.
So she was really neat.
Well, thank you, Mary Beth, so much once again.
My pleasure. Thanks to the two of you. And remember, it's really 82 degrees, sunny, and low humidity.
That's the way to be.
Here in Iowa City. Love it.
Great.
Thank you.
Folks.